Okay, good afternoon, everyone. Happy Wednesday. We are very excited about the webinar ahead. I know we have an hour and a half this afternoon, but just want to go through a couple of quick housekeeping items before I hand it over to our presenter. As always, this webinar will be recorded and the slides will be posted on the We Honor Veterans website within the next day or two. And Marge, who many of you know and work with and love and appreciate as much as I do, is very speedy and will be posting this as well as some other resources on our website. We will be sharing the link to that towards the end of the webinar. I did want to go ahead and give a little bit of an introduction and then just a quick one question poll before we get started. Let's see. Okay, you should have seen it pop up. Just out of curiosity, we wanted to know how you would rate your knowledge of this current topic. Either this is completely new and fresh to you and you're excited to be here, or you could teach this and you're just hoping to learn or hear a little bit more. So we'll give folks just a couple more seconds to get their answers in. All right, looks like this is a new topic for many of you, which makes us even more grateful that you were able to join us this afternoon. So again, we are in for a real treat. We are very grateful as always to be working with the Department of Veterans Affairs and have a myriad of subject matter experts available to present to both VA staff and then our We Honor Veterans partners and community hospice providers as well. So I am very excited to introduce Dr. Grunwald. Dr. Grunwald is Section Chief of the Palliative Care and Hospice Service at VA Puget Sound Healthcare System. He is Associate Professor of Medicine in the Division of Gerontology and Geriatric Medicine at the University of Washington School of Medicine and co-director of the UW Palliative Medicine Fellowship. His wide-ranging interests include the management of symptoms in patients near the end of life and palliative options of last resort near the end of life, including palliative sedation and voluntary cessation of eating and drinking. He is a member of the 2022-2023 class of the Certificate Program for Psychedelic Therapy and Research at the California Institute of Integral Studies. So again, we are very excited that he is here. I'm going to hand it over. If you have questions throughout the presentation, please drop them in the chat box or in the Q&A. We will be leaving some time at the end to have an open discussion. Thank you.
Well, thank you for that kind introduction and welcome this afternoon to everyone. Let's get started. A lot of material to cover. So I wanted to start out with acknowledgements to the Indigenous practitioners and visionary leaders who provide the wisdom, the research, philanthropy, teaching, and organization to advance this entire field. Specifically, wanted to call out Dr. Janice Phelps and Kathy Coleman and the other leaders, mentors, instructors, and learners that I worked with and got to know at the Certificate Program for Psychedelic Therapy and Research at the California Institute of Integral Studies. And an acknowledgement from presentations that I encountered in the program from Dr. Brian Anderson, Dr. Anthony Bassis, and Dick Simon. And finally, an acknowledgement that I'm presenting to you from the traditional unceded lands of the Muckleshoot, Duwamish, and Stillaguamish peoples. Disclosures, these ideas that I'm going to be talking about are my own ideas, drawn from other sources as well, but they don't necessarily reflect the views of the VA or the US government, and I have no other conflicts of interest to disclose. A lot of topics in the agenda, including what are the elements of psychedelic-assisted therapy, which I'll abbreviate PAT, and I'll be talking about set and setting, preparation, administration, and integration phases. We'll talk about the rationale for why PAT might be useful in people with end-of-life distress, some of the benefits and risks that might be important to consider in using PAT near the end of life, and some of the limitations of what we think we know about PAT and how it works. We'll focus our conversation on two agents, psilocybin and MDMA, and we'll compare and contrast them a bit. And we'll also talk about the competencies that would-be psychedelic therapists need to work on and develop. So let's begin. So these plant-based psychedelic agents, such as psilocybin in the form of the psilocybe mushroom, and similar agents have been around for centuries to millennia and have been used in their plant form by indigenous peoples for sacramental and ceremonial purposes. But really, it's only been in the last few decades that we've begun to study the use of these compounds for their medical applications. Unbeknownst to most of us in our world, there were a large number of studies performed in the 1950s and 60s, and they looked at the potential medical applications of psychedelic agents like LSD and psilocybin to treat orders ranging from depression to alcohol use disorders. The results of those studies were quite interesting and promising, but unfortunately, non-medical use of these compounds that became increasingly prevalent during that time led to the termination of research studies. And at that time also, most of these compounds were designated as Schedule I drugs, meaning they were not thought to have any medical value, and they were thought to have high potential for abuse. So what happened then was, for decades, publicly funded research dried up, and the gap was filled by private philanthropists who then kind of picked up the torch of continuing the research. And they looked into, again, the potential applications of these compounds for end-of-life distress, substance use disorder, anxiety, and depression. And so that kind of brings us to where we are now, and the FDA has found the results of these newer studies to be quite intriguing and encouraging, and they've designated psilocybin as breakthrough therapy for treatment-resistant depression and major depressive disorder, and MDA for the treatment of post-traumatic stress disorder. And what that designation means is that these agents are thought to have the potential to be a significant advance over existing treatments. So what about palliative care and psychedelics? Why should we be considering these agents? Well, let's start with the nature of suffering in specialty palliative care. It's not unusual for me to encounter people with persistent suffering, and sometimes it's even refractory suffering that doesn't respond to our standard approaches. And much of that suffering is non-physical. It might be anxiety or depression, a loss of meaning and purpose, demoralization, moral injury, post-traumatic stress disorder, and even suicidality. That's not going to come as any surprise to most of the people on this talk. And in fact, back in 2019, the VA funded a number of projects to try and support community-based hospices to provide some education and training and support around moral injury, PTSD, and suicidality in Vietnam-era veterans on hospice. So VA recognizes the nature of suffering in our population. And yet, the approaches that we have in standard therapy might be ineffective. Sometimes they're not available. They may take too long to act. And there may be other problems, including ethical concerns about one or more of these approaches. So we think about pharmacotherapy that we have, SSRIs and such. And They're effective for many, but not everybody. Psychotherapy, similarly, may be effective for many, but not everybody. And it may take a long time to act, longer than a veteran at the end of life may have. And then we have last resort options, such as palliative sedation. It might be effective for physical symptoms in the last days to a couple of weeks of life when nothing else is working well, but it's not going to help people with existential distress without physical suffering. And then we have treatments, so to speak, such as voluntarily stopping eating and drinking and medical assisted dying. Well, these are last resort options that may be a choice that a person might make where these options such as medical aid in dying are available, but they don't address the underlying problem and they don't really mitigate suffering except through death. Can't we do better than this? And in fact, we know from studies from the Oregon Death with Dignity report that people who seek medical aid in dying, it's usually non-physical causes that motivate them, not the physical causes. So let's see if we can do better. So we enter the realm of psychedelic assisted therapy as a consideration. Its mechanism of action is dramatically different from existing therapies. And really, these agents are thought to work synergistically together with psychotherapy to enhance the therapy treatment outcomes. It's not one or the other, it's both together. And we don't really fully understand how the therapeutic effect works, but what we think, it's the interaction of the drug together with the mindset of the person, which we know in this world as the set of the person. It is the external conditions or the setting in which the person finds themselves, and it's the therapist and the skills that they bring to the encounter. A little bit more about set. It's a combination of the individual's personality, their preparation for this experience, their expectations of what they may encounter, and the intentions of the person in having this experience. Then we have setting. It's a combination of physical, social, and cultural determinants in which that experience will occur. So in the modern era, meaning the last 20 years or so, what we have found is that there tends to be a common structure for psychedelic assisted therapy that has pretty much been followed by most, if not all, studies in this modern era. And it starts with pre-treatment assessment, screening to make sure that as much as possible, we can identify people who may not benefit or who might even be harmed by the experience, such as those with psychotic disorders or borderline personality disorders, might be among the people who should probably not have this experience. We talk to the individual about their purpose in seeking the psychedelic experience, and then begin to talk about what's going to happen during PAT and answer questions. And then we need to be clear with each other about how things might work and work on some agreements and a shared understanding. Sometimes people, especially during psilocybin-assisted therapy, might not be able to communicate in words during the peak experience of their psilocybin session. So having some agreement about how communication will happen non-verbally will be important. Another example of an agreement, no sexual behaviors by any party to this agreement throughout the entire course of psychedelic assisted therapy or thereafter. And then another final example, when you are having this medication assisted treatment, you must remain in the treatment area until it's thought that you are safe to be able to leave. So now we talk about the preparation sessions. This may be several sessions to fully prepare for the encounter. It's a time of trust building. It's a time to explore with the participant or the patient what kind of issues might come up for you during PAT. And the therapist will be exploring with the patient their life history, and as much as possible to help the individual understand what their symptoms are, what their intentions are in seeking this experience, and to identify areas of potential for emotional and psychological growth. Part of that trust building is to have two therapists involved. It may be a male and a female therapist, and they will meet with the participant for several hours, possibly on more than one day. And the goal of this preparation session or sessions will be to build what we might call a safe container for the treatment to occur in. This safe container is physical, it's interpersonal, and it's psychological. It should be safe, it should be comfortable, and the environment should be non-medicalized. It turns out that even studies, for example, of fMRI scans with normal healthy volunteers, just being in that medical setting affected the total experience, and it kind of diluted the experience in a way. It wasn't a safe container in all ways. So the ideal physical container is a non-medicalized environment. Interpersonal aspects of the safe container, having the same therapists throughout the experience, from preparation to medication administration to integration. And that allows the trust to develop over time and to be maintained. And then the psychological aspects of the container. We've talked about trust, and rapport development is an important part of that process. It may be that the participant gets along better with one or the other therapist. That is fine, and everything is welcome there. And then also the psychological part of the container, beginning to understand the material that might arise. So if it's a person with post-traumatic stress disorder, talking about that experience, what gave rise to the PTSD symptoms? What is that experience like for the person? That's all a part of the preparation process. Then we have the medication session. It might be 1, 2, 3 sessions. And as mentioned, the setting should be comfortable, and it should be pleasing to the person, and it should be appropriate for whatever cultural background they come from. That therapeutic role, we're going to talk a little bit more about what the therapeutic role looks like, but suffice it for the moment to say, it's a role of supervised observation in which we are not directing the person from our expertise. We are really trying to encourage the person as much as possible to trust themselves and to be open to whatever arises during the medication experience. So often the advice is trust, let go, and be open. And then the therapist, if it seems that the person is getting distracted from things that are happening in the environment or kind of losing track of that inner experience, the person might be redirected to refocus their thoughts onto their inner experience. And the overarching idea here is that the person knows how to heal themselves in a way, and we trust to the person's inner healing intelligence to really guide the content of what comes up in this session. There may also be a ritual aspect to taking the medication, and sometimes it's recommended that we offer the psychedelic agent in a ritual fashion, perhaps in a chalice or some other ritual container, and we offer it to the person for them to take. So that becomes a choice of the individual in that moment. So to facilitate the medication session, we use pre-recorded music according to a defined playlist. And this playlist is designed to support the experience of a non-ordinary state of consciousness. And the playlist might follow kind of the arc of intensity of the experience. It might start out kind of slow and reach a peak of dynamism and then kind of crest and fall into a more contemplative mode on the other side. Or there might be periods of greater activity and more contemplative periods during the set. And it must be music that's culturally accessible and appropriate for the individual. We also encourage eye shades and headphones. And the idea there is to reduce environmental distractions and minimize any potential pressure the individual might feel that they need to interact with the therapist. If it comes up, it comes up, but let's not have you feel pressure to interact. Just wanted to say one more thing about non-ordinary states of consciousness. In the conventional medicine world, we have often tended to pathologize non-ordinary states of consciousness, and we use terms like psychosis or derealization, and it might be tempting to describe and compare the experience that happens in a medication session with a psychotic experience. So we just need to be mindful about that, because here we're actually welcoming the non-ordinary state of consciousness. And in fact, we're viewing that non-ordinary state as a part of the therapeutic act. So it's different. And so we need to be mindful about our language and our attitudes when we are doing this work. I want to talk a little bit more about a subtle difference in the paradigm between psilocybin-assisted therapy and MDMA-assisted therapy. And going back to the 1960s and 70s, psycholytic therapy was common during that time. It was a sort of talk therapy in which repeated or perhaps even daily low to moderate doses. And let's see, so just something popped up. I'm going to minimize that. So the purpose of these repeated or low to moderate doses of psychedelic medication was thought to increase access of important material in the unconscious mind.
Hi, David. I'm so sorry to interrupt you. It looks like the PowerPoint was closed.
Okay, so how can I help?
Just reshare your screen.
Okay, let's see. So in slideshow and from beginning, or
Yep.
let's see.
To the beginning, and then you can move forward.
Let's see. So I need to go. Where am I? Okay.
Take your time. Really no biggie.
So I'm going to go back here. And share. And can I share screen, or do I need to share another view?
No, it should just be share screen.
Okay. Okay. And then from current slide, yeah?
Yep. And then the 3 dots, like last time.
And 3 dots. And show presenter view.
Yep.
Okay.
Oh.
No?
Sorry, it messed up again. All right, so sorry everyone for technical woes. All right, so you're gonna have to go back and reshare your screen. I'm so sorry. I don't know why PowerPoint is doing this for you, displaying your notes.
Okay, stop share and share screen. And let's go to one of the other screens instead. Yeah? From current slide.
Mhm.
And dots. that working?
Believe so.
Yes? No?
Yep, you're all good. We don't see your notes.
Lots of good. Yeah. A few people have commented sometimes just it's a little shaky. If you wouldn't mind while you're presenting, David, if you could turn your video off, that just may help a little bit.
Okay. Yeah, I'm getting an unstable
Okay.
view. So,
Yeah. Go ahead and turn your video off if that may help.
all right. Better?
Perfect. Yep.
Okay.
And we're back.
So,
Thanks.
all right. Sorry for the technical difficulty. All right. So let's pick up the pace. So we were talking about psycholytic therapy, and then we'll contrast with psychedelic therapy, which involves moderate to high dose medication, 1, 2, or 3 sessions. But the purpose here is a little bit different. It's to induce a transcendent experience to be processed during integration therapy. Now, in the modern era, most recent psilocybin studies have used the psychedelic therapy approach, while MDMA studies have used sort of a hybrid of psycholytic and psychedelic therapy approaches. So I don't want to make too much of the differences between these paradigms, and in fact, there are more similarities than differences, but just to kind of give you more of a sense of what happens in psilocybin assisted therapy. The therapists are non-directive, they provide support, but during the session, they typically interact minimally with the person unless there are needs like going to the restroom or the participant signals a need to interact. Somewhat in contrast, in MDMA studies, Dr. Michael Mithoefer, who literally wrote the book on MDMA-assisted therapy for PTSD, his words are, the therapists act as empathic listeners, trustworthy guides, facilitators of deep emotional expression and catharsis, and supporters of the participant's own inner healing intelligence. And the therapist's role is often to follow rather than guide the participant as they explore new and unexpected perceptions and realizations. So it may be a little deeper exploration, a little more prolonged exploration during the medication session. And then we move to integration psychotherapy. This may start as soon as the medication session effects are wearing off. The participant might be invited to explore their recollections of the experience in journal form, write down everything while it's fresh, and all the insights and inspirations that they, as they unfolded. And so that can be valuable to capture that information for continued exploration during integration, which might continue for some period of time, depending on the study and the way it was designed. It might continue for even weeks afterwards. And the goal of this integration phase is to work with the participant to uncover content and interpret it that occurred and to fashion that into some kind of meaningful long-term change. So what is the message for my daily life in the future? What can I glean in the way of insights or thoughts and ideas that might help me in the future? And if it happened to be that a mystical, ecstatic state happened for the individual, let's explore that. But it might be that profound difficulties, things that are very troubling to the individual, might be the thing that arose, and that would be the thing to work through. Both are welcome, and both are an important part of the therapeutic process. And when difficulties arise to be dealt with, we should not think of that as an adverse event. So before we move on, I just want to kind of summarize that what we've been talking about here is a comprehensive suite of interventions. And we believe that it is this comprehensive set of interventions that is needed for the kind of large benefits that have been reported in many of these studies, as well as to make it as safe as possible for the person and to minimize adverse events. A little bit more about psychotherapy and what happens. It may happen at any point in the process of prep, administration, and integration that we use one or more of these modalities. In the table are just a few examples. We might use elements from each of these modalities, but really the specific mode is largely driven by the person's needs and interests and what the therapist feels sufficiently skilled at to bring to the encounter. It's not a specific protocol that guides psychotherapy. Now, what about the competencies of the psychedelic therapist? In an important article by Dr. Janice Phelps, she outlined 6 key competencies that we should think about, starting with empathic, abiding presence. So the therapist needs to maintain a calm, mindful sense of equanimity and to be open to everything that arises during therapy. We need to be able to enhance trust, and we need to really create that safe container that will allow the person's innate healing capacity to emerge. We need to support in ourselves spiritual intelligence, and we need to be open to and to invite anything that arises. It might be transpersonal, transcendent, it might be an existential mystery that the patient is experiencing, or profoundly troubling difficulties that the person has. It's all welcome. We need to have knowledge of both the physical and the psychological effects of psychedelic agents, the effects of these drugs on the body and the psyche of the patient. We need to have deep self-awareness and ethical integrity to maintain appropriate boundaries, to use power appropriately, and to be aware of any transference or countertransference issues that might arise during therapy. We know from the history of earlier times in psychedelic-assisted therapy that inappropriate behaviors were unfortunately not rare, and we need to really be mindful about that if we're going to roll these approaches out, to be quite mindful about the ethical integrity concerns. And then finally, proficiency in complementary therapies, the various modalities and techniques that were mentioned. It might be psychotherapeutic modalities, including holotropic breath work, acceptance and commitment therapy, etc. We might use somatic techniques, and also art and music might be important modalities. And transitioning now to the effects of psilocybin itself. Psilocybin is a tryptamine. I just wanted to compare the structure of psilocybin and serotonin, and just please note the similarity in structures. So their core ring structure is shared, psilocybin and psilocybin, or serotonin and psilocybin. Psilocybin has a high affinity for multiple 5-HT receptors, including 2A, 2C, and 1A receptor subtypes. And when we administer psilocybin in high doses, which we define as between 20 to 40 milligrams in a 70-kilo person, the effects can be expected to last between 3 to 6 hours. And during that time, there will be alterations in both visual and auditory perceptions. Those might include hallucinations and illusions, as well as synesthesias, in which there kind of seems to be a blurring of the senses. One might feel that you can hear tactile sensations or smell a vision. So that's a synesthetic experience. There may be cognitive effects that range widely from increases in cognitive flexibility or creative thinking or insightfulness, to, on the other hand, distractibility and disorganized behavior may be seen. Affective changes may range from euphoria and a feeling of bliss to, on the other hand, one may experience paranoia or extreme anxiety. And these effects can be quite variable, even unpredictable, and they may be quite changeable even during a single episode of use. So we have some interesting understandings that come from functional MRI studies on the effects of psilocybin. And I want to talk a little bit about the effects of psilocybin on the default mode network, which is a cortical brain network that experiences increased activity and connectivity during times of self-reflection, such as daydreaming, for example, or in depression states. It appears that psilocybin acutely disrupts default mode network activity and connectivity, which in turn allows disruption of established patterns of thought and behavior. And so this may be, at least in part, one of the reasons why psilocybin seems to result in an increased ability to develop new perspectives and receptivity to change when we administer psilocybin together with the psychotherapeutic approach that I've been describing. Now, I want to turn your attention to the figure, which shows one aspect of 3 separate studies in which participants were asked to rate an item called "My Thoughts Wandered Freely." And we see in the gray bars the ratings of who received placebo, and in blue bars the scores of people who received psilocybin. And it's pretty obvious that the markedly higher scores in the psilocybin groups were seen in each of the 3 studies. And this was thought to suggest that psilocybin promotes an unconstrained style of cognition. And now I want to transition a bit to some of the data that we have on psilocybin in end-of-life distress. Starting with a study by Charles Grobe in 2011. This was a pilot study, a double-blind randomized controlled trial of psilocybin for anxiety and depression in patients with various advanced cancers. And in this study, subjects acted as their own controls. There were 2 sessions that were given in random order, either starting with or receiving later psilocybin in moderate dose at 0.2 milligrams per kilo, which amounts to 14 milligrams in a 70 kilo person, compared to niacin placebo. Now, in the graph, we see that one measure of depression, the Beck Depression Inventory score, it did not change significantly from baseline to 2 weeks of follow-ups. But what we do see is that there are divergent paths with the lines diverging progressively. And by 1 month, these were of borderline significant different. And the psilocybin group then remained significantly improved compared to placebo at 6 months. And that was a significant finding. There was also a measure of anxiety in this study, which was significantly lower in the psilocybin group at 1 and 3 months after treatment. So it's a pilot study, but intriguing results. Then we have a little bit larger study, study number 2 by Griffiths and his group in 2016. This was a double-blind crossover randomized controlled trial. 2 sessions of psilocybin for anxiety and depression in various advanced cancers. And the study employed high doses of 22 or 30 milligrams of psilocybin in a 70 kilo person, compared to an active control, which was low dose of 1 or 3 milligrams of psilocybin in a 70 kilo person as the active control. Now we look at the graphs and we see results for the psilocybin first group in red and the active control first group in blue. And in the upper graph, we see that psilocybin produced large and significant decreases in measures of depression in the upper graph, and in the lower graph for anxiety, and that these results were sustained at 6 months. And that improvement was partial in the low dose first group. And then when they finally receive the high dose, then they come fully down to the same level of improvement as the psilocybin first group. And then in both groups, we see that the finding is maintained at 6 months. So the overall response rate, which was defined as a decrease of at least 50% in scores compared to baseline, were 78% for depression and 83% for anxiety. And then symptom remission, which was defined as a score at or below a threshold level of 7, occurred in 65% of subjects for depression and 57% of participants for anxiety. So a lot of excitement around this study. It looked quite good. Right at the same time, Ross's group also published results. It was also a double-blind crossover randomized controlled trial of psilocybin for anxiety and depression in various cancers, most of which were advanced cancer. And they used a single high dose of 21 milligrams of psilocybin per 70 kilos compared to a niacin placebo. And the graphs, I'm just using a selection of graphs from the study. There were quite a few graphs that they published. So these selected data shown for the pre-crossover portion of the study with the psilocybin group in purple and the placebo group in blue. The graph at the upper left shows a measure of anxiety, and the graphs at the upper right and at the bottom show 2 measures of depression. And for all 3 measures, the curves for the psilocybin and placebo groups diverge immediately after the medication session, with significantly greater reduction in symptoms with the psilocybin at all time points afterwards. And what is more, the effect size was large at each time point, at least 0.8 at each time point and for each of these measures. And then at 6.5 months of follow-up, psilocybin was associated with enduring anxiolytic and antidepressant effects, such that 60 to 80% of participants continued to have clinically significant reductions in depression or anxiety. And they also found that psilocybin induced a mystical experience in many patients. And the attainment of a mystical state was highly correlated with the therapeutic effect of psilocybin on anxiety and depression. So I want to talk a little bit more about psilocybin and mystical states. So again, this correlation of benefit seemed to occur with the occurrence of a mystical experience. And this was thought to be evidence that achieving a mystical state might actually mediate the benefits of psilocybin on anxiety and depression. So when we talk about a mystical experience, what are we talking about? We're talking about unity, a sense of oneness or interconnectedness of all things and all people, a transcendent experience of time and space, a sense that time is endless, it's an infinite realm without boundaries. Positive mood is deeply felt, including a sense of joy, peace, and love, a sense of sacredness, and an experience of awe and wonder. Humility and reverence are a part of that experience of sacredness. It's a noetic quality, a certainty that what you are experiencing is the ultimate reality. And it's also an experience that is impossible to describe in words, although dependably, participants did try and express their experience in words. Now, it should be acknowledged that this correlation between clinical effect and mystical state is not the same as causation. And so we need to kind of continue to explore the evidence. Here is one piece of data, the dose response effect. So what we see here in normal volunteers is that psilocybin produced dose-related increases in a measure of mystical experience that was validated. And the percentage of these volunteers who attained a complete mystical experience, and that means according to all 6 dimensions that we were just talking about on the last slide, that experience was an increasing function of dose, such that at the lowest dose, only 5% of subjects achieved that mystical experience that was complete. But at the highest dose, over half of subjects attained that complete mystical experience. And here are some data also from the second study that I showed you. So this is an end of life set of data. Use the Mystical Experience Questionnaire 30. And on the left, we have a measure of anxiety correlating with the total mystical experience score. And on the right, we have a measure of depression, and we see the correlation there. And we see a moderately strong correlation for anxiety and a moderate correlation for depression in this study from 2016. So I want to just take a step back to ponder the implications of this work. And I was thinking back to an essay that influenced me profoundly. Actually, it was important in influencing me to go into palliative care back at a much earlier stage of my career. This is an essay from Eric Cassell, and his words about transcendence are as follows. Transcendence is probably the most powerful way in which one is restored to wholeness after an injury to personhood. When experienced, transcendence is not isolated by pain, but is brought closer to a transpersonal source of meaning and to the human community that shares those meanings. So I imagine that many of you on this call have seen this happen in people near the end of life, that they attain this experience of transcendence. And so if it happens to be ultimately facilitated by a medication and by medication-assisted therapy, perhaps that is a profoundly good thing. Now let's talk a little bit about not end-of-life care, but data from studies of people with moderate to severe anxiety and depression. A meta-analysis from 2020 looked at some earlier studies. 3 out of 4 of these studies were placebo-controlled, randomized controlled trials. And those 3 placebo-controlled trials all had large effect sizes that were significant statistically. And by large effect size, I'm talking about at least 0.8 in all 3 trials, according to the outcomes they looked at. And no serious adverse effects were reported. Looks promising. So where did we go from there? There was another study that compared psilocybin to a standard SSRI treatment in major depression. This was a double-blind randomized controlled trial published in 2021 by Dr. Carhart Harris and his colleagues. And 2 doses of psilocybin, 25 milligrams, 3 weeks apart, together with 6 weeks of daily placebo, were compared to an active control of 2 doses of 1 milligram psilocybin, 3 weeks apart, along with daily escitalopram for 6 weeks. So this was a complicated way to compare psilocybin and escitalopram. And the primary outcome was change in baseline depression score at 6 weeks. Now I want to have you look at the upper graph where you see the effect of psilocybin versus active control on this measure of depression over a 6-week period. And the control is shown in blue and the psilocybin group in red. And we see that although depression ratings tended to be lower than escitalopram at all time points, the difference didn't quite reach significance. In the lower graph, we see a measure of well-being, and this was a secondary outcome that was looked at in this study, one of quite a number. And we see that the psilocybin group scores tended to show more improvement, but unfortunately, the analyses didn't correct for multiple comparisons. And so they didn't feel that any statistical conclusions could be made. So intriguing findings. It kind of looks like psilocybin was better in these outcomes, but it didn't reach the statistical barrier. So we can't say anything about statistical significance from this study. Then there was a larger study published just last year for psilocybin in treatment-resistant depression. And this was a multi-site randomized controlled trial, involved 22 sites in Europe and North America of one dose of psilocybin-assisted therapy. And the doses range from 25 milligrams to 10 milligram to an active control group using 1 milligram of psilocybin together with psychotherapy in all groups. And in the graph, we see plots for the active control of 1 milligram psilocybin in purple, and the 10 milligram doses in green, and the 25 milligram doses in blue. And we see that a single dose of 25 milligram psilocybin, but not 10 milligram, improved depressive symptoms after 3 weeks, and that finding was significant compared to 1 milligram. And at the 25 milligram dose, 37% of participants responded at 3 weeks, and that was defined as a decrease in depression score of at least 50%, but the response was no longer significant at 12 weeks. Adverse effects, mainly nausea and headache, were seen quite prevalently in all 3 treatment groups, including controls. And no mystical experience measure was obtained. So that would have been nice to know what patients, if any, achieved a mystical state. So these are interesting findings. It should be noted that this was quite an ill population, and a few participants in all groups reported suicidal ideation or self-injurious behavior, and the investigators concluded that in future trials of psilocybin for depression, we need to be vigilant for worsening suicidality. So what about the safety record of psilocybin? A few points from studies that have looked at safety over time. We haven't found data to suggest that psilocybin precipitates a new psychotic illness, but the concern has remained that in susceptible people, we wonder if psychedelic agents might unmask a psychotic disorder. We just don't know. What we can say is that these studies tended to screen participants for a history of psychiatric problems. And in this group, we don't have short or long-term evidence of prolonged psychosis, perceptual disorders, or functional impairments in these healthy volunteers. So kind of one bottom line for our studies and for any future clinical use: supervision during psychedelic experiences will be strongly recommended for safety. There is a very interesting online survey that was done, I think it was by Dr. Griffiths' group. And this was an online survey of users of psilocybin, almost 2,000 respondents who were asked to describe their worst bad trip after psilocybe mushroom ingestion. And almost 40% rated it as among the most challenging experiences of their lifetime. 11% put themselves or others at risk of physical harm. And in those whose ingestion of the mushrooms was at least a year prior, 7.6% sought treatment for psychological symptoms related to that experience. So those are concerning findings. And nevertheless, even though it was difficult, 84% thought that they benefited from the experience, and 3 in 4 reporters said that they had increased well-being or life satisfaction as a result of this experience. So this online survey isn't rigorous enough to serve as a guide for clinical practice, but it does point out potential concerns with the use of psychedelics in uncontrolled settings. And now let's talk about MDMA. So for MDMA, we only have one small study that I was able to find in people who were seriously ill and probably near the end of their life. But there are more data suggesting that MDMA is potentially quite useful in PTSD treatment. MDMA is not a classic psychedelic agent. It's classified as an empathogen or entactogen, are terms that are used to describe the class of MDMA. And its effects are partially overlapping with psychostimulants and with serotonergic psychedelic agents, including LSD, ayahuasca, and psilocybin. And it's structurally similar to mescaline, which is the active agent in peyote buttons. And I just want you to take a moment to look at the structure diagram and to notice the similarity between MDMA and mescaline. Its main mechanism of action actually are multiple. Like LSD and psilocybin, it activates the serotonin 5-HT2A receptor, and it has mixed effects on serotonin, norepinephrine, and dopamine reuptake, inhibition, and release. And so the effect of those actions is to increase the circulating levels of those neurotransmitters. MDMA was used by some psychotherapists in the late 70s, early 1980s to enhance the effectiveness of psychotherapy. So that kind of harkens back to the psycholytic treatment paradigm a bit. The non-clinical use of MDMA became increasingly popular under the names ecstasy or Molly for non-medical use. And this increased non-medical use raised big concern on the part of the DEA for abuse potential. And so that led the DEA to designate MDMA as a Schedule I drug in 1985. And in the late 1990s, that designation was made permanent. Then in 2002, in the magazine Science, the journal Science, there was a primate study that reported neurotoxicity at moderate doses of MDMA. And it turned out that the primate subjects were actually given methamphetamine, not MDMA. And even though the study raised a furor when it was published, the study was then retracted. So what are the MDMA effects that we have seen? In healthy volunteers, it has a panoply of effects, including euphoria, empathy, well-being, insightfulness, gregariousness, positive mood, and extroversion are all seen. Increasing access to emotionally intense material and the ability to sit with that material is seen, as well as increased interpersonal trust and compassion for oneself and for other people. The cognitive perceptual effects include deficits that are short-lasting or brief in spatial and verbal memory and concentration. There is mild psychomotor impairment, so no driving your car or heavy equipment while under the effects of MDMA. There are slight visual and auditory alterations that can be seen that are modest in comparison to psilocybin, and rarely are hallucinations seen. There may be unpleasant affective symptoms, and anxiety is common in study participants. And in those who have participated in PTSD studies, Grief, fear, and rage are relatively common to be seen. But it's important to think back to a comment I made earlier in the presentation, that these are not adverse effects of MDMA per se. These are common as things that arise in people with PTSD who need to experience what is going on inside them. So we need to be very careful about how we view grief, fear, and rage. Because of the psychostimulant type effects that it shares in common with the psychostimulants, autonomic and cardiovascular effects are common, such as increased energy and transient mild increases in heart rate and blood pressure, or tachypnea. Other effects include reduced appetite, muscle tightness, and grinding of the teeth, or bruxism. It is thought, and it's a little unclear to me how this conclusion was reached, but it is thought that MDMA has mild abuse potential, perhaps through the highly prevalent illicit use of ecstasy. But it should be noted that in clinical studies, one rarely sees illicit use of ecstasy after MDMA use in the clinical context. So perhaps it remains to be seen in future studies. So MDMA effects, by contrast to psilocybin, do not appear to be mediated by the mystical experience. And we know that from phase 2 studies in which the mystical experience scores on the MEQ-30 were not correlated with PTSD symptom reduction. Instead, the reduced fear of traumatic memories, increased feelings of trust and compassion towards self and others without sensory distortions, or problems with inhibition of access to the difficult emotions that arise may be mediating, so that MDMA can increase the effectiveness of the psychotherapy experience by making those traumatic memories more accessible, and also to strengthen the therapeutic alliance. So now let's talk about the data. MDMA for anxiety and serious illness was studied in this small pilot study. It was a double-blind, randomized, controlled study of 2 8-hour sessions with MDMA compared to placebo, together with integration psychotherapy in both MDMA and placebo arms. And there was an additional open label phase of the study, and ultimately all participants received 3 sessions of MDMA before study completion. The participants, almost all of them had various forms of cancer. There was one participant that had a neuromuscular illness, and all participants had moderate to severe anxiety. And the outcome that was studied was anxiety symptoms at baseline compared to 1 month after the last medication session. So in the graph, we have a measure of anxiety on the y-axis with the MDMA results showing in orange and the placebo results showing in blue. And on the left side of the graph are data at baseline compared to 1 month after the blinded medication sessions, and then 1 month after the last open label session. So that's the 3 time points in that plot on the left-hand side. And we see here that the MDMA group tended to have a greater reduction in anxiety scores at both time points than the placebo group, but that didn't reach significance. However, the effect size appeared to be large at 1.03. So compare that to greater than 0.8, which is itself a large effect size. So even though significance wasn't reached, it appears that the effect size of MDMA in end-of-life anxiety is large, potentially. We just can't prove it from this study. I'm not going to present the phase 2 data for MDMA and severe PTSD. We've advanced to the phase 3, and this is a study of 90 participants. It was a multi-site, double-blind, randomized controlled trial in chronic severe PTSD, and 3 and 4 participants were white in this study and really quite seriously ill. So over 90% of participants had a history of suicidal ideation, and suicidal behavior was seen in 1/3 of the participants at some point. So psychotherapy with MDMA was one arm of the study, and placebo with psychotherapy was another arm. And there were 3 sessions, 4 weeks apart. And the MDMA dose ranged from 80 to 180 milligrams in divided doses compared to placebo. Outcomes that were studied included PTSD symptoms based on the CAPS-5 score, and functional impairments at baseline compared to 2 months after the last medication administration. So here are the results. There were improvements in PTSD symptoms at 2 months. So I want to direct your attention to the upper graph first. We see a measure of PTSD symptoms on the y-axis and changes in scores after sessions 1, 2, and 3 as we go from left to right. Data from the placebo group are in blue and the MDMA group in red, and we see a significant and progression of lower and lower PTSD symptom scores in the MDMA group with a large effect size of 0.91. Then in the middle graph, we see a measure of functional disability that improved somewhat more modestly, but still significant in the MDMA group, with a moderate effect size of 0.43. And then in the lower graph, we see a measure of depression, which improved more in the MDMA group with a moderate to large effect size of 0.67. So those were impressive data and have formed the rationale for a second phase 3 study in a more diverse cohort that will be published soon. I want to talk a little bit about the availability of psychedelic-assisted therapy in 2023. We all need to keep in mind that psilocybin, MDMA, and other psychedelic agents are still Schedule 1. So for the nation as a whole, we are still in that full stop phase. But things are kind of opening up around the edges, specifically in Oregon and Colorado. So Oregon State has facilitated use of psilocybin that will be legal starting this year. And Colorado approved a measure that creates a framework for psilocybin use in mental health care and therapeutic settings more generally. But in both states, the regulatory framework is still under development. So what I think we can say, and this is going to be this is my opinion, but I think these licensed centers in the 2 states are going to be the proving grounds for safety and efficacy of broader access to psilocybin-assisted therapy, and probably more generally psychedelic-assisted therapy in a broader range of conditions as well, and in some cases, well persons who are seeking spiritual growth. So this kind of sets up some potential for tension and actual tension between mainstream entities and those who would advocate for greater access. So already we have seen the American Psychiatric Association oppose the Oregon measure that resulted in legalization. Did we just lose our connection?
Oh, we can hear you, but the slides are gone again.
Okay, sorry about that.
That's
Let's see if we
okay.
can. We will go back.
Sounds
We will share. See if my skill level has improved at all. I am screen sharing. And are you seeing anything yet?
We see your screen. It is back at slide 13 though.
Okay, I'm at slide 44. So, I probably shared the wrong screen. Okay, I see. All right. This is not. Okay, how's that?
There we go, perfect.
Okay.
Oh yeah, you were right at that first bullet when we lost your audio. You were just talking about how it was opposed in Oregon.
Okay, yes. So then we have veterans who are asking for and receiving these psychedelic treatments outside the healthcare system through whatever avenues are available to them. There's a veteran service organization, the Heroic Hearts Project, that is helping veterans in this way to obtain ayahuasca sessions in Peru for those with PTSD, where ayahuasca is legal. And so, as one who cares for veterans, I want veterans to have access to things that help them. And I want to protect veterans who may not be appropriate candidates, who might potentially be harmed by treatments. So that's kind of the tension here. And more research is really going to ultimately be the way to identify who's going to benefit and who's not going to benefit. So that's the tension. And so just kind of holding that tension is a part of where we are now. And then finally, advocates are suing the DEA on behalf of terminally ill cancer patients who wish to access psilocybin therapy for their end-of-life care under the Right to Try Act. So that's already happening, and it hasn't been fully adjudicated yet, but they've been pushing pretty hard. So we'll see. So what can we say about concerns with approval of PAT in medical settings? There's risk that overall with generalizability based on current studies. There's low participation of BIPOC and minoritized sexual groups, other marginalized groups, and many studies have excluded those with severe mental and physical illnesses. Overall, the numbers of study subjects is small compared to the hundreds of subjects in phase 2 trials and thousands in phase 3 and 4 trials of other approved medications. We don't know about vulnerable populations and their balance of benefits and harms, and the potential for substance use disorder should be further studied. After approval, if that happens for one or more compounds, there will likely be risk evaluation and mitigation strategies required. Those might be pretty restrictive, and depending on how this goes, there may be a proliferation of unregulated, possibly unsafe off-label treatments. That is kind of the paradigm of what's could happen, is what we have seen with ketamine treatment clinics. We may find that payers balk at rolling out the full psychotherapy, the full comprehensive package. There may be pressure to limit costs and availability of psychotherapy. And then commercialization might increase access more quickly, but it might exacerbate inequities based on ability to pay and where the treatment is available. So time is short. I'm going to just say that culturally informed adaptations are very important, and there's lots of work to be done at every level, and we need to include culturally diverse leaders and Indigenous leaders in all aspects of this work. We're going to need lots more clinicians when and if this rolls out in all disciplines, and the estimated need is large. In the reference and resource list is a list of psychedelic training and education resources, not screened for how good these programs are, but there's quite a list. So that's in the reference section.
Hi, David. I'm sorry to stop you. Your slide is still on the one on the Heroic Hearts Project. If you could just advance a few to the yeah, to where you're at.
Okay, well, all right. So we've kind of,
There it goes. Yep.
all right.
Perfect. Thank
So
you.
we're just going to wrap up here. So lots more providers are needed. We need to establish standards and competencies. And there are 2 emerging associations and boards that are helping us with this. And so here's the summary slide. Here's my thank you. I'm going to leave the summary slide open, and I just want to open for discussion and chat.
Okay, well, I have to say, I don't think I have ever seen quite a busy webinar chat box or so many questions in a single webinar. So I definitely see that as a positive. I know lots of folks are asking for the slides. Absolutely. They will be posted along with the webinar recording on the We Honor Veterans website. Em, if you could post the link in the chat box. We have created a psychedelic assisted therapy resource page where this information, as well as the links to a couple of organizations, articles, videos that were mentioned here will be linked, as well as any policy updates that come down the pipeline. So again, we just want to be able to share as much information as we can as possible to make sure everyone is informed on this rapidly growing field. So thank you again for sharing those resources. We have quite a few questions. I will talk fast. Anything else, if anyone has any that aren't answered or that come up later, please feel free to email us at veterans@nhpco.org, and we will do our absolute best to get those answered. So David, while I am posing a couple questions to you, I am going to ask folks to answer just the final poll. It is 2 tiny questions. Okay, so that poll is launched. We would appreciate if you would answer. Okay, so questions going. Oh boy. There was also quite a lot of feedback. I did just want to share some thanks. Thank you for the acknowledgement of the land and Indigenous peoples, so appreciated. A few people did share some research playlists that are available on Spotify. There is one by Johns Hopkins Psilocybin Research Center. There is also an artist named John Hopkins that makes playlists for psilocybin journeys. Let's see, someone did mention in my work as a chaplain, I've seen similar outcomes from patients who describe intense near-death experiences. The transcendent experience reduces fear and often makes lasting positive impacts on a person's life. Okay, so now on to a couple of questions. Is there a particular reason why 2 therapists are present for the pre-assessment session?
Thank you for that question. Yes. One is to kind of have a check and balance because of the misbehaviors that have occurred in the past. Having 2 therapists in the room is thought to be important for trust building and maintenance, and to sort of provide an ethical check on each other. And then having a male and a female therapist is thought also to kind of provide, again, that sort of protection that might occur if you have just one or the other. So that's controversial, that last point.
Okay, thank you. Is there a particular next one. Why is borderline personality disorder an exclusionary diagnosis?
So that's not a universal standard for exclusion, but in terms of trust, let go, be open, sort of at every level, a person with borderline personality disorder may have difficulty. And so the attempts to include such individuals have not gone well in past studies. So it's that anecdotal experience that has led to that as a suggested exclusion.
Okay, thank you. Let's see, can you speak to whether this type of therapy might someday be available to everyone, regardless of ability to privately pay for it?
That's going to be largely up to regulatory agencies, and they need to be satisfied that the data on efficacy and safety are adequate for approval. So in terms of widespread rollout of these approaches in the medical environment, it really depends on that. So for the non-medical environment, that's a little bit of a different question. And Oregon and Colorado are testing those boundaries. But in terms of accessibility, that, I hope I touched a little bit on that in the comment about payors and the incentive to reduce costs. I think that's a problematic area for access. And these high intensity approaches are likely to be expensive. And who's going to pay if not the payors? So that creates an access problem. And those challenges are going to continue, I think.
Great, thank you. While the effects might be difficult to predict, are there any known factors that seem to increase risk of experiencing intense negative effects in response to psilocybin?
Yes, I would say in a nutshell, it's failure to establish a therapeutic safe container in any of its aspects, whether it's physical or psychological or interpersonal. And one area of particular concern is people who come from a marginalized cultural or racial or sexual background. If they are minoritized, their experience may be different from those who come from sort of the privileged white high income group that tends to be the people who seek out and receive these approaches. So that is a major area of concern. And that's why rolling these approaches out with a broader diversity of therapists, a broader range of study participants, and just kind of infusing this whole area with trauma-informed care is really, really important. And I'm sorry I had to rush through that one of those last slides.
No, thank you. And I saw that there was sort of a generally posed question, but someone did just mention in the chat box as a non-binary clinician, I wonder how that standard will affect me.
You mean in terms of the male and female therapists?
I believe so, yes.
Yeah, so that is the controversy I referred to. Already, that's a very 1980s way of thinking about this in a way. And so in 2023, expanding our idea of what constitutes a good therapeutic safe container really must include a diversity of therapists and participants. So the person who raised that question is absolutely on target. Absolutely.
Okay, I think we got time for just a few more. Is there a big range of differences of perceptions of seeing, hearing, smelling, and or touching that patients report after the medication-assisted sessions? And are some of those experiences in any way similar to what people report after near-death experiences?
I don't really have the expertise to answer that question. There is certainly quite a range of synesthesia experiences reported that I've seen, but exactly who develops which kind of synesthesia and whether near-death experiences are similar, I really can't answer that last part. So I'm not well informed about near-death experiences. So my apology.
No, that is a great answer. There was a question, what settings are generally used for the administration of the doses? Hospitals, doctor's offices, anywhere else?
It has kind of depended on where the study funding comes from, who's doing the work, and Karen Cooper from CIIS gave a presentation on sort of making do with the space you have. If it's in a hospital where this is going to be done, then making a hospital room as pleasing and as non-medical as you possibly can is part of the challenge. If you've got a clinic with lots of space and it's quiet and it's modern and well furnished, you might not have to do very much, but it really depends on what you have. This whole field has kind of been funded on a shoestring in a way, and there has been no systematic sort of comprehensive government funding of these research studies. So it's a good thing to highlight. We need that more systematic, kind of large scale approach to really ramp up.
Great. Okay. I will say there was a question about differentiating between mystical experiences and spirituality, followed by there was a lot of input from attendees in the chat box regarding that, which the chats will be saved and shared as well. But if there's anything that you wanted to comment on that as well, please do.
I'm not quite sure what question or what angle to take on that. Was there a particular concern that came up?
That was the general question. And then as an example, one answer was there was some qualitative research or retrospective research on mystical experiences, but it's sometimes just not as possible to study in a controlled manner. Yeah, and then just some discussion around that.
Yeah, well, maybe what I'll say is we are in a primitive state when it comes to defining what role a mystical experience might actually have. And this really calls out for more qualitative work to see if there is some aspect of experience that seems to come forward. And so doing qualitative studies, that would be a logical next step to take. We've kind of talked about statistical correlations, but that doesn't really get at the heart of what's going on here. And perhaps that underlies the questions that come up. So these participants have identified the next step for us to take in research when it comes to unpacking this correlation and determining how important it is. We may end up finding that it's not only the mystical experience that's important, it might be various other aspects of spiritual distress, and unpacking that becomes equally, if not even more meaningful for the individual. So, for example, if one says that maybe a given participant says, I felt like all the meaning and purpose has just disappeared from my life, but since this experience, I now have come to understand there's more to life. Even now, when I'm near death, there's more to life and more purpose and meaning for me. But I didn't have a mystical experience. So I think it's the qualitative research that's really going to allow us to unpack that more. Does that make sense?
Mm-hmm. Thank you. I know we're right at 4:30, right on time. Again, I'm I know there were a few questions that we didn't have a chance to get to. Again, we will be sharing more information, including a lot of the resources that Dr. Grunwald shared on our resource page. I really can't thank you enough. There has been a ton of feedback saying that this was incredibly informative. And folks are very thankful for your presentation today and that it was just fascinating. So Dr. Grunwald, you will likely be hearing from us again. But just to everyone else who attended, thank you for your time again. And again, everything will be up on the website, the recording, the slides. And if you have an idea for a topic or perhaps a speaker that we may not be aware of, please let us know. Send them our way. We're always looking for new folks or topics to highlight. So please let us know if you have anything in mind. But otherwise, yes, thank you to Dr. Grunwald and the Department of Veterans Affairs for their ongoing collaboration. And thank you all today. Thank you.
Thank you.